start off? Yes?
Yeah, sure.
Yeah, so good afternoon to all who have logged in. Thank you for joining in. My name is Dr. Aswini. I'm one of the ophthalmologists working here at King's College Hospital, London. So I passed my FRCS Glasgow in the year 2018. So my exam experience may not be as crisp because it's a few years ago. You might be more aware of the correct answers than me, but I will share with you my experience, and you can learn from my mistakes and how to do better in your exams. Yeah. So in short, I will be covering my preparation for the exam, my experience during the examination, and what I did after my exam to get my first job in the UK, and why I feel working in the NHS is worth it. So the pros and cons of the NHS, and how I secured my first job, and how I've moved in my career, and what is the scope for any international medical graduate to grow further. Yeah. So I start. So do you see my slide along with everyone's photographs, or do you see my slides as such? Should I hide any screen?
No, fine.
It's fine, yes. Right, so for my exam preparation, basically everyone has a different purpose why you're giving these examinations. For me, the purpose was to clear the examination so that I become eligible for applying for jobs in another country. Initially, my target was to move to Singapore, but then after the exam and due to my change of circumstances, we decided back to go to UK. So my motivation was, as my husband was employed in Singapore, and I needed to step up my qualifications to match the criteria required. I had to clear these examinations. So everyone has their own motivation and purpose to clear these exams. So although it wasn't easy preparing for these exams alongside working full time and being a mother of 2 children, so I sorted out my time based on, although I was doing my fellowship, my time was pretty tight. So what I did was, instead of going through books, I made soft copies. I downloaded books from Telegram. So everything's available on the phone these days. So I read most of my books over the phone, be it daytime, nighttime, or during travel. There is a lot of time we get during travel in the train. So that is one of the time that I made use of to clear these exams. So sources of these exams, part 1 obviously was quite easy, John Ferris and Forrester, although I preferred John Ferris more, and some Elkington for refraction, although refraction played a very small part in the first part. And I went for a direct route through FRCS instead of going the bypass route via FICO. So I gave my part 1 FRCS. Then I gave my part 2 FRCS, that is part 2A and B, out of which part 2A I found quite challenging in terms of time management during the exam, as the questions itself were quite long during the first time I attempted. So it took me a lot of time to actually go through the question, analyze them, and go through the multiple choice. Each question you would be roughly given about 40 seconds. So in my first attempt of part 2A, I did not clear, which was an eye opener for me. So I gave it again, and so this time I made sure I stick to the time. I look for the keywords and plan my answers accordingly, and I was better prepared, so I could clear the part 2 in my second attempt. Then I went ahead for part 3 preparation. When we apply for the part 3, it's sometimes you're on waiting list, and because of limitation of the number of centers based on where you're situated. So I had a waiting list number 1. So I wasn't sure if I will be let through into the exam or not. However, I continue with my preparation. as when you're on waiting list, you get to know that you are through to the exam, very close to the exam date. So you can't let go of your arms down. So I continued with the preparation. So my preparation lasted for 6 months to a year, where Muthuswamy sir's virtual university played a major role in my preparation. So Dr. Vijaya Ranjipe was one of my mentors who supported me very well. So the faculty used to send me a scenario. I used to formulate answers and send them back. They go through them and reply back with better way for answers and what is more correct. So that really helped. Then I did attend a 2 days course on FRCS Part 3 Glasgow at Lakshmi Eye Institute. You may find courses all over the world where you live in, but this is one course that really helped me. And Dr. Rashmin Gandhi and Dr. Devendra played a key part in my success. I really go by the Chua website. It has a treasure of knowledge. When you go into each of the topics, there are subtopics and questions and scenarios that really prepare you on the method of answering and how to go about these exams. So it's a wealth of knowledge I would strongly suggest to explore. Regarding books, I did go through the Wong textbook. There was one Indian textbook called Rashmi Mittal, which I really liked, which had a vast, good explanations and case scenarios, which really helped. Although sometimes when you go too much into detail, it might be quite overwhelming, especially when you're facing an examination which is really time bound. You hardly have like 6 minutes per session, and you have to cover a lot of cases within that time. So your mind should be quite streamlined to answer what exactly the examiner is looking for. Yeah, and obviously I did go through Kansky. Most of the pictures given in Kansky can be really useful because when you go through your part 3 day 1, which is a Viva Voce, most centers may use laptop and digital pictures, but sometimes it could be a printout or a photograph, which can be quite blurred and may not give you sufficient information. So that was the case in our exam. We were handed out printouts, which were zoomed in and not something that you will tune you to look for the exact diagnosis. So that's one thing you need to be aware of. Then, of course, Oxford Book of Emergency Medicine is a must, not just to clear that emergency medicine station, but also it gives you a vast overview of how to handle your ophthalmology-related cases and what you need to look for to avoid any mistakes, to miss any sight-threatening or life-threatening complications. So all you're expected in the exam is to be a safe doctor so that you don't miss any ocular emergency which can be sight-threatening or that is associated with a systemic condition that can be life-threatening. So if you come across, if you bounce most of these boulders, you're more or less safe during the exam. Yeah. And I did use some of the Telegram groups. So if you download Telegram and you can type in the keyword FRCS Glasgow Part 3, you will find groups that are there who are, which has a number of doctors preparing for similar examination. They do case discussions and they have soft copies of the books they read and advice. So if you go by those, if you just manage to read the case discussions that are already there, it's a vast treasure of knowledge there. And I did form small WhatsApp groups with the friends I found on these training platforms, with whom I used to discuss cases, not just what I see, but what I read. And we used to present photographs to each other, showing case scenarios and how you would describe what are the questions you may come across, what are the differential diagnoses and how do you manage them. So that we did that not in the form of typing, but in the form of audio notes. So that helps because at the end of the day, you are not going to write in the examination. It's all about what you speak. And although you know a lot of things, if you come across as not being confident, or if you come across as if you're not able to get the right words at the correct time, as it is a lot of the exam point is time bound. So if you're not able to go get the exact words that the examiner is looking for, also it may be limited by the communication gap, and some of the examiners may be from different parts of the world whose accents you may not be familiar with, and they may not be familiar with your accent as well. So it happened that with one of the examiners, I couldn't understand what questions they were asking. So it's okay to ask them to repeat. You can say them that you did not understand, so they will repeat the question for you. But it's a two-way system. So even if I answer the correct point, the examiner didn't get it, so he asked me the same thing again. So that's one thing you need to be aware of, and be wary of different accents, and try to be a good listener. Also, because the exam station is not just going to be you and the examiner, but there will be multiple stations happening in the same hall. So there will be a lot of noise from the other candidates trying to answer, other examiners asking other questions. So you should be really tuned to what your examiner is asking you, and try to cut off other noises around you. So be prepared for a lot of distractions, but try to be focused. Yeah. So that's something that helped me prepare for the examination. And the examination part 3, I will go in detail. So as such, part 1 was what I said, Ferry John Ferris mostly. Part 2 and B, part 2B was mostly descriptive, for which the Oxford Book of Emergency Medicine really helped. And part 2A was mostly time management, Kansky and Mickelson, and books like that, and mostly your knowledge on overall ophthalmology. Although it depends from what subspecialty you're practicing in, your strong points may vary in different areas of the exam. So part 3 was again divided into viva voce on day 1, and the clinical scenarios in day 2. So when we go to day 1, my first station was posterior segment. So like I told, it was a big hall with 3 stations, with students trying to answer simultaneously and trying to be louder than each other so they can get to their points. So there will be a lot of distractions. So in my first station, which was posterior segment, I was quite confident because my subspecialty is medical retina. So to get a station that you are strong in, it always builds up. And my weak area was always anterior segment, though things are quite obvious in anterior segment and you don't have to look for the diagnosis. But the questions can go quite complicated, and the answers expected, although are quite easy, you may not come up with the correct answer at the right time. Yeah. So first we started with posterior segment. One of the examiners handed me, feel free to stop me at any point and ask questions. I'm just going on presuming that all of you are listening. So first station, the first examiner handed me a photograph of a large neovascularization towards the arcade. So that was the only thing that was seen. The rest of it was all blurred, and asked me diagnosis. So so I started giving a differential diagnosis of first diagnosis being proliferative diabetic retinopathy. He asked what else could it be? Radiation retinopathy, sickle cell retinopathy, old vein occlusions, what I say. So he said, so if it is a diabetic, a 50-year-old, how would you go about managing it? And mind you, these photographs are just of the one eye. So you should always say that you will examine the other eye, you will look for vision, you will do an OCT scan of the macula to look for macular edema, and then go about deciding a plan of treatment, whether you would treat the macular edema first or the laser first. And then, so they asked me, what are the agents you would use for treating diabetic macular edema? Why would you prefer one agent over the other? And so how do you go about lasering? What will be your settings? What will be the number of spot size? So went on from there. Then the next examiner handed me a picture of a white lesion on the retina, a subretinal lesion, and said this is the picture of the fundus picture of a child. So it more or less looked like a retinoblastoma. We went on to ask about management of retinoblastoma and what are the other lesions which can present similarly, all white fundal lesions, differential diagnosis, and give differential diagnosis of leukocoria. So what are the causes of leukocoria? So we went ahead with that. By then, the third examiner showed me a fundal picture of few pigmented spots on the retina with a white halo around it. So it looked like congenital hypertrophy of RPE. They asked for differential diagnosis of, you will obviously talk about a choroidal nevus or a choroidal melanoma, and then the questions went on to how do you differentiate a nevus from melanoma. And one of the examiners did ask, what is one simple investigation you would do when they come for follow-up? So I was thinking of investigation, something that is big, but they had to ask twice for me to get to the answer of saying that you would do a fundus photograph to monitor them, and we could do an OCT across the lesion to note the thickness of the lesion. And then they go on to management of choroidal melanoma. So we've had retinoblastoma, choroidal melanoma. Then another examination meanwhile showed me a a photograph of an acute red eye. Sorry, did I do that? No. So an acute red eye with hazy cornea, shallow mid-dilated pupil. Sorry, okay, shallow anterior chamber with a mid-dilated oval pupil. So, and asked, what is your diagnosis? So it was an eye of an acute congestive glaucoma. Basically, don't waste time in saying that I'm seeing a hyperemic eye with a hazy cornea with a shallow AC. You can go briefly about it, but go right to the diagnosis because they are not looking for your ability to look for the findings on the photograph. But to discuss management with you. That will be the case in your clinical discussion where they will want you to not miss any findings, especially in your slit lamp examination where you have to really describe each finding that you see. So in this case, acute congestive glaucoma, they ask you for the management. So you go step by step and say you would do this and this and this. You measure the eye pressure, you see the hazy cornea, what are the eye drops you would use, beta blocker, alpha agonist, and pilocarpine, and IV mannitol is what I said. So immediately the question was, what percentage of mannitol? So 20%. So how much of mannitol? So it would be 1 mg per kg body weight mannitol. So these are certain percentages and certain numbers that you need to remember, especially when it is acute emergencies. Especially ophthalmic emergencies. If you don't remember the dose of, let's say, phenytoin given in acute convulsions, that's pardonable, but you can't, because you're an ophthalmologist and trying to streamline the patient to an acute medicine person. But any ocular emergency, you're expected to know full and full, as you will be the doctor handling the patient completely. Yeah. So that's something that will, and the discussion is to make sure that you have handled these emergencies and you are in a position to confidently manage these emergencies if you are the only doctor in the eye casualty that day and you're a safe doctor. Yeah, so that's the way of going about it. And then sometimes the questions can be quite vague. As in, I said, okay, we go in for a therapeutic PI for one eye, and the other eye will have a prophylactic PI. So the doctor, the examiner asks, what if the PI fails? So obviously, if you're a doctor who is used to handling these patients, you know that if a PI fails, you go for cataract surgery. But at that point, I did not answer cataract surgery. I said, I would choose surgical PI. And then he was like, what if that fails? Then I said something vague like trabeculectomy, which is not the correct answer, which I wouldn't have done if I were to treat that patient. But when you're in the exam situation, all these vague things can come out, but be very focused to try and understand what is the key word the examiner is looking for. And sometimes it could be quite vague, especially with the doctors that you are being examined by come from all over the world, and certain words can be quite different in managing patients. Like I had one station where a doctor asked me, what do you call a lacunar or crescentic graft used for a PUK? I'll come to that. Wherein I said it is a crescentic graft or a lacunar graft. He said, no, it's a banana graft, which I've never heard. It might be my limited knowledge or my subspecialization not being cornea or anterior segment, whereas in that part of the world, banana graft might be something that is commonly used to explain that kind of graft. So these are things that you need to be wary of, and don't get disappointed if an examiner is not impressed by you or shows a disappointed face. Try to get over it within the next few seconds, because you have a lot coming in the next few minutes, which can decide whether you clear that exam or not. Yeah. So meanwhile, the next examiner showed me a picture of a glaucomatous disc. Now, and said, how would you manage? So you don't go by saying that I would do vision, I would do eye pressure, I would do sleep time examination. Now these are things that you will do in all the patients, but that doesn't convey any message to the examiner. So instead of saying that, you would say, I would want to know the age of the patient, the vision of the patient, what is the other eye status, whether he's already on drops or not, his eye pressure and the trend of his eye pressure over time, whether he's using drops or not, and his visual field changes, and then decide on the treatment and decide on the target IOP, decide whether you want to go medically or use lasers or want to go surgically if these measures fail. So go about it like that. Yeah. So the second station was neuro-ophthalm, motility, and emergency medicine in one station. So the first question to me was, so they don't hand you diagnosis like what I've written here, but one of the question was, if you're operating and one of the patients in the waiting room starts to get disoriented, confused, and has a sweet smell in his breath. Now these are keywords that should ring bell in your head. So has a sweet smell to its breath. So I said, could be a diabetic who has gone into diabetic ketosis. He said, how would you manage? So you get a rapid blood sugar done. You see whether it is hypoglycemia or hyperglycemia. And I said that we will correct the dehydration first by giving 0.9% saline infusion, then going for insulin with 5% dextrose infusion. And he said, what else would you do in terms of managing the patient? So I said his surgery might have to be cancelled, and I will write a letter to the GP informing about the incidents and the need for alternate treatment if there is. So they do expect answers that tell them that you are confident to manage the patient, not just in terms of drugs, but the overall how the patient will be handled with multiple subspecialties, especially in this station. So then the other examiner asked me, how would you manage the patient with diabetes as a general practitioner or as a general doctor? So then, apart from drugs, so he didn't want to know what are the drugs you will use. He wants to know how will you manage, what are the other aspects you will look for. So then you have to mention about the diabetic foot care, neuropathy, how you'll manage nephropathy, other social factors that play a hand, smoking, his driving status. These are all things that you will mention. Then there was a question about a patient who comes to you with intermittent headaches and failure to adapt that eye, but there is normal reading ability. So basically, he wants to say there is normal convergence but adduction limitation, which happens in internuclear ophthalmoplegia. Now, if the patient were to be young or old, there are different diagnoses. Either it's a demyelinating lesion, or is it a vascular lesion or a GCA? So then the discussion went on about managing the internuclear ophthalmoplegia. Then the fourth question was, he handed me a photograph of one eye swollen disc and said it's a 40-year-old obese female. What comes to your mind? I said I would like to look at the other eye to confirm if it's disc edema or papilledema, and the differential diagnosis most likely is benign intracranial hypertension or pseudotumor cerebri. To confirm which, I would do an MRI brain and a CSF analysis. So now the moment I said CSF analysis, he said, okay, the MRI brain is normal and the CSF pressure is 16. I don't know what the normal CSF pressure is. So, when you say these things, remember that you will be given values and they will expect you to decide whether it's normal or not. Now, after that, we went on to discuss about the management of pseudotumor cerebri. He said, what are the other investigations you will do? I said, we will do a visual field analysis. And he asked, what are the visual field changes you will see? So I went on to describe a few of the changes like centrocerebral scotoma, enlarged blind spot, and note the mean deviation. So he said, how would you treat and follow up the patient? I said it will be hand in hand with a neuro-ophthalmologist or a neurologist, treating with intracranial pressure lowering agents like Diamox. Sometimes they may need a lumbar puncture repeatedly. And how would you follow up the patient? So basically, you're asking for symptomatic relief. You would do visual fields because you can't keep repeating MRIs often. So you will see the mean deviation reduce as the intracranial pressure settles down. So that's one thing. Then we went on to my anterior segment, which was not very good. So it was anterior segment along with lids and plasty. So my first examiner handed me a picture of an eyelid lesion, which had telangiectasias over it. I said, I would like to know the age of the patient. If it's an old patient, it could be a BCC. If it's a young patient, the diagnosis is different. So he said it's a 10-year-old. Okay, that helps. So he said, is a 10-year-old boy who comes with this lesion. So I said it could be a molluscum lesion. So he went on to ask, how would you treat this lesion and what are the other features that you would find if it is a molluscum lesion? So I said there might be papillae on the palpebral conjunctiva, there may be allergic conjunctivitis, and there may be other anterior segment features. He wanted to know them. And he asked me what are the other viral infections that can cause eyelid lesion. So herpes simplex and herpes zoster can cause rashes over the eyes, and human papilloma virus can cause papilloma. These are what I said can cause skin lesions or eyelid lesions, although you can include other viral infections that cause palpebral conjunctival, papillae, and pseudopapillae, and trachoma. You can include these. So the second question from another examiner was, so do you do phaco's regularly? And at that point, I wasn't doing phaco's. I was more streamlined into medical retina. So he asked me, what if when you are doing a phaco and during trench, something suddenly happens, and what would that sign be that will alert you for a PC rupture? I said pupillary snap sign, wherein there will be sudden dilatation, momentary dilatation of pupil and sudden deepening of anterior chamber, but by mistake I said there will be shallowing of anterior chamber, and I was done with that. So wherein they were quite disappointed with my answer. And although there are some examiners, even if you say the right answer, they will show you a disappointed face. So don't get carried away. You carry on with your answers and try to be focused. So then there was a discussion of, okay, if you're trenching and you notice there is PCR, how do you handle it? I said I would stop the phacoing, I would stop the power and the irrigation, but I will not pull the phaco probe out. I will lower the bottle height. I will loosen the speculum. I will ask the patient to take a deep breath to lower the eye pressure. Immediately they were like, who would take a deep breath? Is it the doctor or the patient? So it's both ways. And so then it went on to the other part of management. Basically, they wanted me to know, they wanted to know how would you manage a PCR if noted right at the beginning of the FICO. How would you manage it differently? Now you can form your own answers based on your experiences. I'm not the best person to guide that. Then there was a question of a mother bringing a 9-month-old baby with watering eyes. How would you manage it? So basically, firstly, I said differential diagnosis of watering in a 9-month-old. Then went streamlined to congenital and NLD obstruction, which was what the discussion was about. So they did ask me, what would you do, advise the parent? I said lacrimal sac massage. Then they asked me, how do you do the lacrimal sac massage? I explained how to do the massage and demonstrated it on myself. And then they asked me, if it fails, what would you do? I said probing. And they asked, what would you do along with probing? Or if probing fails? I said, we do probing, and then next step would be Jones intubation. They said, no, what would you do along with probing? So I was thinking in terms of other investigations, but the answer was sac syringing, which at that point was very obvious, but I did not understand what they were asking. Obviously, you do sac syringing along with probing. So then there was a picture of a large crescenting ulcer, peripheral corneal ulcer, and asked on what are the differential diagnoses, what would you be wary of? So I said I will first rule out life-threatening conditions like vaginous granulomatosis and rheumatoid arthritis. I will look for the systemic association. Then how would you manage it? I said lubricants, NSAIDs. Then he said, what else can you use? I said cyclosporin. He said, I was looking for that. Then they said, how would you manage surgically? I said, you could use a partial thickness graft. And so I said, then they asked me, how would you suture it? So I went on to say, like an expert, we would use 90% depth and use 1/3 towards the graft and 2/3 towards the host and suture it this way and that way. And they said, no, what if the tissues are macerated? How would you hold the graft? And I said, we will use glue. They said, no, glue is not available. Now what? Then I was thinking, and they said, okay, don't you use amniotic graft? I said, yeah, we can use amniotic graft. So what do you call that graft? I said, a crescentic graft or a lacunar graft. No, banana graft. Haven't you heard that term? I said, no. I was quite disappointed in that station. I hardly had any hope of passing. Then there was a picture of a completely blown up picture of an eyelid papillae with a corneal ulcer. So I said it's a shield ulcer with a vernal keratoconjunctivitis and went on with management of that. But any answer I would give was welcomed with a disappointed expression in that station. So I had no hope of passing that station. So that ended my first day. So, and we went on to the second day of clinical scenario, which again started with anterior segment. So we were about seven candidates in the afternoon session. When you have the afternoon session or day 2 of your Viva, and there are other candidates who have already passed, who have already had the examination experience, kindly refrain from discussions about what the cases were. Ideally, they change the cases, but in our setting, they did not change the cases. And few of my friends did discuss as well. But don't attempt to discuss with your previous candidates, as the answers they will tell you is their interpretation of what the cases were, and they may not be the cases at all. And even as I am telling you the cases, these might have been wrong as well. But what they are looking for is the way you approach each case, what differential diagnosis you have in mind, and how you approach the case, than to know what exactly the diagnosis is. And unlike our undergraduate and post-graduation examination methods, where you're expected to tell a lot of theoretical knowledge and what steps you would go through, that ends with your Viva Voce itself. When you come to this clinical setting, you will answer every question as if you are treating that patient by yourself, and what are the steps you would go through to manage that patient. So in my anterior segment, I faced with an unfamiliar slit lamp, which I struggled adjusting My height wouldn't suit the slit lamp wouldn't move down, my chair isn't moving up, I couldn't find the lever, because I was giving the exam at a different part of my country, where the equipments are manufactured differently, the settings are there differently, and that varies with different parts as well. So get yourself familiarized with different kinds of slit lamps. If you fumble, don't hesitate to ask for help. There were about 8 people sitting in the room, and you have like 6 minutes to finish that station. So the first station, I struggled with that. I struggled with the light. There was a not so expected case. I saw a limbal scar with a large superior iridectomy and a malpositioned IOL with an optic capture. So I said, this is a case of extracapsular cataract extraction with optic capture. So, and the other eye was a phaco surgery, pseudophakic. So the questions were more towards what would you do if you see 1 week post-op this patient? What are the things you will look for? So I said I would see vision, look for signs of corneal decompensation, look for signs of infection because it was an eventful cataract surgery, look for high eye pressures as the vitreous could be in AC, the IOL is malpositioned. What else can you do if you're seeing soon after the cataract surgery? I said I'll put dilating drops as an attempt for the IOL to reposition. And what are the things you will look for if it is 3 weeks post-op? And then the discussion went on regarding complications of cataract surgery. Secondly, there was a case where there was a diffuse corneal opacity to covering this lower half of the cornea, and the eyelashes turned inwards. Now, whenever you get an anterior segment case, remember to look for the eyelids, and the cornea, sclera, and remember to elevate the upper eyelid to see if you're missing out anything. If I haven't elevated the upper eyelid, I would have missed that Eki scar. I would have not known that it was an extracapsular cataract. So the first thing you need to clear an anterior segment is list out all the findings that you're seeing. Now, in this case of corneal opacity, there was a bandaged contact lens in place, which most of my colleagues missed. That's because they failed to elevate the eyelid or failed to look away from the cornea, where the thin edge of the bandaged contact, and mind you, bandaged contact lens is not like a normal contact lens, it's quite thin. You wouldn't really notice it unless you look for it, you look for the edge of the contact lens. And apart from trichiasis, there was frothy discharge, meibomian gland dysfunction. These are findings that the examiners expect you to tell. Even if you fumble at the diagnosis, even if you fail at some bits of the management, you are still you may pass, but do not miss any findings on the anterior segment especially. So then the discussion went on to what are the causes for corneal ulcer, trichiasis, what infections you would look for and stuff like that. So then I'll move on to my second station, which was posterior segment. Now, normally as a medical retina specialization, person, I am quite well versed with indirect ophthalmoscope, which is commonly used in my part of the world. And although that was the case, on that day of the examination, I could see nothing through the indirect ophthalmoscope. Firstly, because I was towards the end of the exam and there were a lot of fingerprints on the 20D lens, and the equipment was unfamiliar. The patient was seated at a different position than that I would normally have, like on a proper slit lamp chair, which is reclinable or seated higher. Now this person was seated low, and I'm struggling with another examiner peeping behind and trying to expect answers from me. So I could not focus with the indirect ophthalmoscope. I said, I can see some hard exudates and that's it. I can't look for more details. I'm unable to. So he allowed me to look through the 90D, which was very kind of him. So despite that, I passed that station. So I looked through the 90D. I saw there was moderate NPDR with diabetic maculopathy. They asked me management of diabetic maculopathy, why you chose this drug over another, what would be the schedule, and why is there asymmetry in both the eyes? Now, the causes of it could be different. Could be carotid stenosis. It could be a cataract surgery in one eye that aggravated. There could be a superimposed vein occlusion. So the discussion was good. Then the second case was one eye with a large white PED seen at the macula. The other eye had dry AMD. So then it was clear this eye was a wet AMD. We went on to the discussion of wet AMD. He asked me, what if other eye was normal and you're seeing this white lesion at the macula? I said it could be a secondary from elsewhere in the body. It could be a lymphoma. He asked me, what other findings will you see if it's a lymphoma? I said vitritis. And he said, what would you see if it's a secondary? I said, it might be multifocal, but I don't know as I have not seen the periphery. And this time I used the indirect ophthalmoscope. I could see the periphery as I was more confident, more calm. And I said, there are no lesions in the periphery. And then they asked me what are the, and I said it could be amelanotic melanoma. So remember, whatever you give the examiner, your questions will go on from there. So feed the examiners wisely. So then my discussion went on to amelanotic melanoma. And that was a posterior segment. It went on quite well, although I did not use the indirect ophthalmoscope in my first case, which is not acceptable. Okay. And then I went to the neuro-ophthalm station. They asked me to do a cover test. So cover test, I started with doing a Hirschberg's test, which was, and this station, I could do confidently because of my training at Panvel Lakshmi Eye Institute and under the guidance of Dr. Ashwini Prabhakar, who made sure all of us were well versed with these neuro-ophthalm examination. So I started with Hirschberg test, did the cover test. I saw there was an exotropia. There was exotropia on distance and near. And then I asked for the vision. Then the conclusion was causes of exotropia, that is same distance and near. Then there was another patient. He asked me examine the motility of the patient. Now they are trying to see how confident you are in examining, and do you do this routinely. So my examination was quite confident in terms of motility. I did all the 9 quadrants, and there was one eye with a corneal scar, and I did the saccades to end with. And what was it? Yeah. So after the saccades, I concluded that there was an adduction deficit in that eye, and the vision in that eye was quite poor. So it was secondary to poor vision in that eye. Now, these kind of cases may not be typical what you expect, but it depends from center to center. If you choose a center that is a tertiary eye center and has good inflow of cases, you may get typical classical exam cases. But if you're not, or if it's a bad day, or if they find a few cases in the outpatients that in order to fill in for the missing cases, they will put in atypical cases and don't be prepared for that. Yeah. And then there was a case of confrontation test. So he told me to do the confrontation, and I saw that there was left homonymous hemianopia. So I said I would like to look for its peripheral extent, do a perimetry. Then they handed me a perimetry and said, this is the visual field of the patient. There was left congruous homonymous hemianopia. So I said, they asked, where is the location of the lesion? I said, it could be behind the optic chiasma, either in the optic tract or in the occipital lobe, more likely occipital lobe, because more posterior lesions give more congruous lesions. And what would you like? What are the causes you would rule out? I said it could be vascular or tumor, and I would like to do a parietal lobe test in terms of looking for pursuit, and go for Cogan's dictum, with which I would decide whether it is a tumor or a vascular lesion. They said, why can't it be demyelination? Then they asked me features of my MS, my multiple sclerosis. What are the other systemic features you would get? So that station went okay. So then I went to oculoplasty. When I entered the plasty section, I saw this young boy sitting there who was quite thin, emaciated, who had patches of hair loss, and he had a facial asymmetry. His skin was quite tight, one eye was quite prominent. So by my instinct, I thought it was unilateral proptosis. I went ahead examining proptosis. I did the Navziger test, and I said, okay, there's no asymmetry. The Navziger test is negative, so it is pseudoproptosis. And meanwhile, the patient, while I was examining the patient, there was nothing else abnormal I could find. And eventually, after all the discussion of proptosis, the patient blinked and the right eye had a lag of ophthalmos. So the asymmetry was not pseudoproptosis or proptosis, it was lag of ophthalmos due to facial nerve palsy. And then there was a discussion about Fowell syndrome, and he said the patient cannot hear. Now it could be CP angle tumors, and probably the patient was on chemotherapy or associated features of malignancy, which is why he was thin, emaciated, he had hair loss. So this is one unexpected case where I was deviating towards something else, but later on streamlined. Although I did well with the discussion of the various neurological causes like Fowell and CP angle tumors, there was a discussion on how you would differentiate different types. Then there was a case of tense swelling in the lacrimal sac area. So they asked me, how would you differentiate from other lesions? So you know the level of the MPL, the lesions below it are more likely sac, above it are more likely to be something else. So would you do a CT scan in this case, and how would you manage it? So demonstrate a Rho plus test. So these were the things. And then my third case was a microphthalmos. So by the time I just told the diagnosis, the bell rang. So remember to gather more cases during your examination. In this station, I lost a lot of time in my first case, so I could only cover 3 cases. So by the end of my 3 stations, my confidence of passing was quite low. So when we came out and discussed, although most of my batchmates were quite confident, they said I said this and that and this and that, my confidence was quite low. But at the end of it, when the results came, I was the only one who passed among the 7 in the batch. So that was quite surprising. Being critical is good, but somewhere they would have seen the diagnostic skills and your knowledge as a whole, and not missing findings, I think, is what helped me. Because although my colleagues were quite confident, and some of them did get deviated by discussing with the previous candidates, where the diagnosis could have been totally wrong. And you just remember that these are the cases that are there already. So you try to fit in what you see to what you already know by your discussion with your friend, which may totally deviate you within those 6 minutes. Yeah. So that's how I passed the examination. Now I'll go on to discuss what I did after the examination. Any questions so far at all? So I take that as a no, or everyone's sleeping. So after that, I went on to give my English test. So either you can choose to do your IELTS or OET. I chose OET personally because it's more streamlined to the kind of work I do, and it's not irrelevant to what I normally don't listen to. So there are 4 parts: listening, reading, writing, and speaking. You can get study materials of the OET or any English test and practice along with it. Not very difficult, but there are people who have attempted multiple times, and you have to get at least a B in all 4 sessions in order to clear the OET. So I could clear it luckily. And after I did the OET, I went on to apply for my GMC registration alongside applying for my first job in the NHS. By when I had decided I will not take up a job in the Singapore, as the grade they were offering was quite low. And from my discussion, the scenario may be different for different people. I learned that the career progression is quite difficult and it is quite competitive there compared to if I moved to the UK. So then I weighed the pros and cons and I applied for my GMC registration. The requirements for the GMC registration was a recognizable postgraduate degree, which is not your MS ophthalmology that you did back home, not your postgraduate degree. Now the FRCS becomes your postgraduate degree that the GMC recognizes. Along with that, they need your basic medical qualification, that is my MBBS at my home country. This has to be verified by an international body like EPIC. So when you go into epic.uk, that's a website to create your electronic portfolio of international credentials. Now this body will verify your degrees. They will send their own inquiries to your place of basic medical qualification and the Royal College in order to verify whether you have completed the degree or not, and if it is approved or not. So the Royal College, I had no problem. They sent the inquiry. The Royal College sent a feedback to them, and it was done. But to get my EPIC verification for my MBBS degree, I had to go to the college and pay my EPIC registration fees to the college so that they can respond. Now, when they reply back to the EPIC verification, they will normally send it by normal registration post, which takes about 2 or 3 weeks. But when you have a deadline, you can personally choose to up that by sending it by courier, and you pay for the courier, and that will fasten the process. So you get your EPIC verification done, and they will send a feedback to the GMC saying that these degrees are valid and they are actually, this candidate has done these things. Yes. And then you get your OET scores or your IELTS scores, you submit that showing your English language proficiency. Then they also require your internships certificates showing that you have done such and such rotation in all the departments and you're a safe doctor. So you give your internship certificate and your certificate of good standing. Sorry. Now this certificate of good standing can be got from your medical council, local medical council, where you've registered. So I went to Karnataka Medical Council as I was registered there. Now after the GMC registration, why I decided to choose NHS and move to the UK. Firstly, it's a public funded system, which is one of the largest employers in the world, has world-class facilities. And because it's public funded, I am not restricted in choosing my treatment options depending on the patient's pockets. And I'm away from the trust issues from the patients. And I'm not decided by a second doctor opinion, or I'm not looked at as I'm advising something in order to make money. So these trust issues are gone, and I can do my treatment, which is textbook based and evidence based, instead of looking at what the patient can afford. And one of the things that really, I felt the difference was there is zero tolerance to violence against doctors, which is very important. And so that's one of the pros. It's your job is safe. You are in a secure system. If you get a permanent job, then it is permanent for life, unless you do something which takes your registration away, or you land up in legal issues. So you have a secure job, and your job plan is set. You have set working hours. You have a good work-life balance. Your weekends are free if you choose to do so, or if you want to do on calls, or if you don't want to do weekend work, you can up that with an extra pay. And you have a paid annual leave of 28 to 32 days, depending on the grade of doctor you are. And that's quite nice to know. Then you have a good career progression. You could get the GMC registration either way using a PLAB route, but when you have your FRCS, the grade of job you will end up is better than what you get through a PLAB route. Yeah, and no doubt with your clinical experience is better, your eye for picking up keen diagnosis is better, your clinical skills are way ahead of others, or doing a PLAB route. And here you will find there are standardized protocols for every procedure. So whether you're a new doctor or old, you just have to follow those protocols. There will be guidelines that you can follow, and your errors are quite limited because there are so many safety checks happening all the time. And the work environment is quite pleasant. People are quite nice. And not just at workplace, generally people outside are quite nice. There's no road rage, and driving is quite pleasant. The education system is less burdening to the children, and in terms of safety to the children, it's a very safe country. And what else? There is, yeah, so whatever subspecialization you do in your home country doesn't get wasted when you move to another new country, which can happen if you go by, let's say, USMLE route. You, although you're a pediatrician or an ophthalmologist, you end up doing internal medicine all over again. That doesn't happen. So if you've super specialized in, let's say, medical retina, you get to do medical retina here. If you're cornea, you get to do cornea here. That's something nice. And you don't have to learn a new language, unlike going into some other country, and you have to learn a new language to interact with the public. That doesn't happen here. And there is good chance of surgical opportunity, which is very important, which I really struggle back home, because everyone would give you medical retina, everyone would give you OPDs, especially at odd hours, but nobody wants to give you surgeries, especially in private practice. So that's one thing. And also you don't end up prescribing glasses, and things are quite streamlined and set at different layers. So you are seeing patients that are already seen by opticians and referred to you. So you have to look at that one thing and look at ophthalmology as ophthalmology, not like a refractionist. Although you will still need your refraction knowledge when you plan your cataract surgeries, when you treat pediatric patients, but you don't end up prescribing glasses, and you're handling GP referrals. The patients are already looked through for their systemic condition by the general practitioners here, and they refer you the patients that you need to look for ophthalmology. And you're working in mostly a multi-specialty hospital, which has all the departments. So it's more, your exposure is quite wide. The experience is nothing like it. It's something like working in a medical college, which is quite nice. And those were the pros. Especially, also, there are some cons. Now the cons, especially, is the distance from your home country, and if you have elderly parents, you do miss them. But it's about a 10 hours flight, which is the case if you are anywhere else in my home country and trying to get through bus or train. And then there's the weather. It's quite cold here, especially 6 months of the year. So yeah, if you're okay with that, that's good. Then childcare is one thing that I really struggle with, and it's quite expensive here in the UK. And housing, most of your a significant fraction of your salary goes into your rental or your housing, and taxation is quite heavy here, unlike other countries. But at the end of it, you weigh the pros and cons and what works best for you, what are your preferences, and you choose it. And also, one of the things I found was the disadvantages. I speak about 5 Indian languages, which is of no use here. Although I get that one odd patient where I can show off my skills, but that's one thing I found difficult. And Indian food, or wherever you're coming from, if the kind of food that you're used to may not be here unless you cook, or it's difficult to find places that give you authentic food, although you get somewhere near for a heavy price to pay. And obviously you have to go through the transition, and that's quite a stressful period from your home country to here, and new workplace, new work scenario, especially learning names of new people. You make a joke when you call out people's names in a wrong way because you're not used to these names. So those are the small issues. So what I did for my applying for my first NHS job is, so I used NHS jobs website. You can even use BMJ careers. You can use agencies. Like what I used was ID Medicals, which worked good. They do help you tailor your CV in order to match the requirements of the NHS jobs. And they did arrange one interview for me, and I cleared that interview. So I had one job offer in hand. Meanwhile, I found another interview through NHS jobs. And so because I had one offer in hand, I could negotiate better and opt for a middle range of the pay range, and not the starting range, which was actually first offered to me. So because I had another offer at hand, I could negotiate, and although your experience back home may not be considered completely in the UK, it's usually halved. So if you have 10 years of experience, including your post-graduation of 3 years back in your home country, it's usually halved and you're taken about 5 years experience. Although that happened in my first job, and you end up taking what you get. But if you can negotiate for a better pay point, you can get it there. And after about a year or so, you can move trusts. And when you move, you can negotiate, like what I did. I moved from my first trust to second trust, and right now they did consider all my 10 years of experience back home. So that's a good transition to make. And the first job may be both difficult to crack, and you may have to compromise, because the GMC registration, although they do a provisional GMC registration, the last step of it is the ID check, for which you have to be physically here. Now it's up to you whether you want to take a visiting visa and travel all the way from your home country, come here for the ID check, maybe attend a few couple of interviews and go back, or you decide to get the job, move here, and do your ID check and start off with your job. So that's what I did. GMC gives you 3 months of period before you get your first job and move here, or choose otherwise to get your ID check. So I chose my first job. I accepted an offer. I moved to the UK. I did the ID check on the second day of my landing here, and then I started my job later on. So when you need to come to the UK, so all right. So for my first job, there are some Facebook groups that I used as well, like IMG group, that is International Medical Graduates group. The group is quite helpful. If you have any queries regarding your transition, your first job, or even while you are at job, this group always has never failed, it has never disappointed me. So any queries you post in the group, somebody will be there to answer your queries. Yeah, so that's quite a helpful group. These groups can be looked for in ophthalmology, and if any of you want to join, you can message me and I can add you in. Yeah, so that's that. And for the first job interview, now they will ask you about your journey so far. What are you good at? What are you not? And there will be certain clinical scenarios that are discussed, especially from emergency cases in eye casualty, like endophthalmitis, like corneal ulcers, or a patient giant cell arteritis. Any ocular emergencies can be discussed here. Maybe a quick discussion of a panel of 2 to 3 doctors, senior clinicians in the department may interview you along with an HR. Now, how to prepare for this job interview? And for your first job, some common questions need to be prepared. Although you know the answers for all the questions, it's difficult to come up with that one scenario when they ask you in the interview. So if they ask you regarding one difficult case, or one case of PCR, or one incident that you were involved in, or something that did not go right, or one angry patient, how you handle. So these are things that you need to already prepare answers for, so that when they ask you, you can quote the instance. Few of the common questions asked are, why this job, and why do you want to work in this trust, and why do you want to move to the UK? So you look through the website of the trust that you're applying for, look at the values, and look at the place where you're applying. Do a little research and a study about the trust, the place where you want to live, and the clinicians who are going to interview you. So look for their subspecialty, and like what papers they've written in, and what interests they have. The questions are most likely going to be from there. And they will ask you, what are your career objectives? 5 years down the line, where do you want to be? Where do you see yourself? Or 10 years down the line, where do you see yourself? So be really streamlined on your answers. What do you want to do in 5 years' time, if you want to become a consultant or not? Now, there are different types of jobs you can apply for. I'll come to that. Then they would ask you, why do you think you are the right fit for the job? So be prepared to say your experiences, and your leadership skills, your subspecialty, your what you're good at, and why you would fit this job perfectly. So come up with a good answer. Be prepared beforehand, so you don't fumble there. And then what are your strengths and weaknesses? This could be a general question. And like strengths could be something like able to work in high work pressure, in tight, what do you say, tight appointment schedules, or handle good cataract load. You might be a good proficient cataract surgeon, or punctuality, pleasant to work with, any of your general attributes as well. So feel free to highlight these. And your weaknesses could be, shouldn't be something that will tell them that, okay, you're not a good candidate for this. Don't say that I don't know lasers if you're applying for a medical retina job, or I don't know to do phaco if you're applying for a cataract surgeon's role. So weaknesses could be something like something that you have but you have overcome, like you're impatient but you worked on it, or your cataract skills were low but you took training to overcome that, or like my weakness is, one of my weaknesses is remembering numbers, so I write them down. So any dosages, these are my weaknesses. Anything to do with numbers, I find it really hard. So something like that. And they will ask you about some challenging cases that you've dealt with, how you are as a team player, how you arranged for a case to be sorted using a multidisciplinary approach. How did you handle an angry patient? Or if you do something wrong, like you inject a drug in the wrong eye of a patient, how would you do that? How would you handle that situation? So you talk about duty of candor, where you're better off informing the patient and raise it as an incident rather than putting it under the carpet. And then they will ask you about incident reporting. One of the key sections of interview in the NHS is what is your knowledge about governance and audit. So basically, what is governance or audit? So it's nothing but there will be a preset standard to every procedure or every aspect or every patient care activity in the hospital, and you're trying to see how much this procedure is matching to that standard level, and if it is not, by how much, and what are the methods you can use to up the standard, and where are we failing, and are we doing something about research, teaching? These are all aspects that come under governance. Yeah. So there are different jobs that you can again, negotiating when you get the right offer, based on your experience, based on your other offers, and you have a time constraint. You have to, if you're planning to move to the UK, do it within that 3 months in order to avoid a flight charge and a visa charge. And to get the visa, the requirements are different. You need to have a certificate of sponsorship from your employer. So once you accept the offer, the hospital will sponsor you a certificate of sponsorship, for which each trust will pay an amount and get that. So kindly do not withdraw your offer after they release the COS, because it can be reported to the GMC and your registration may be at a risk. It's not a nice practice. It's unethical to do that. So once you accept the offer, kindly move to the trust and work for it. Even if you plan to resign, do it after 3 months notice. Yeah. So they will give a COS that is issued in your name. You can use that to apply for your visa. Now, when you move to the UK, you will also need your English proficiency, for which I think recently OET has been accepted by the UK visa. But previously that wasn't the case. Either you need to have IELTS, or there is another route called UK NARIC, wherein you go to the UK NARIC website, and you can upload your English language certificate. So in my case, either you apply to the university, you need something called as a medium of instruction letter, which says that your education has been done in English, and so your English standards match to the required language standards of the UK. So you can either apply to the university and get the proficiency English proficiency certificate or medium of instruction letter. Or in my case, what happened is my university, that is Rajiv Gandhi University, in their website already display a a preset letter saying that all the courses that we conduct in this university are by default in the language of English. So that is your medium of instruction letter. You can just download that copy and send it across to UK NARIC. This is physical copy by post. And they send you a physical copy saying that your English language is approved, and your internship certificate, your academic certificate can also be sent, and the UK NARIC approves it. So these are all regulatory bodies that say that your certificate is at par with their standards. And then you need a police clearance certificate, for which you apply to your local police station, and it takes about 10 to 15 days or sometimes longer to get your police clearance certificate, depending on the countries you've lived in the past 5 years. So you need to get police clearance from all the countries that you've lived in. So I had to get from here and from Singapore, as I lived there for some time. So with the police clearance certificate, and you get your tuberculosis clearance certificate. So that is by there are reputed centers that the UK visa approves in order to get the TB clearance certificate. So you look for that in the visa website, UK visa website, and you go to the centers that are nearby, get your chest X-ray done, and they will clear you for TB clearance certificate. With all these 4 documents, you apply for the UK visa. And once that goes through, you will be the main applicant. You can sponsor that for your dependents as well, and you can move with family if you want. That is excluding your parents. Your parents are not considered dependents here. So that is one con of moving to the UK. They are allowed on a 6-month visitor visa, after which they have to move back to the home country for at least 3 months. Yeah. So career progression, firstly, when you apply for a job, either you can apply for a training job or a non-training job in the UK. For a first job, it's better that you apply for a non-training job, because you get that much of time to get used to the system, how the NHS works. And what I chose was to apply. With my experience, I qualified to apply for a middle grade doctor. These are doctors who are neither trainees nor consultants, but they belong to a non-training post. The doctors are either called specialty doctors, or a more senior role would be associate specialists. So you apply for any of those roles, and then if you want to up from that scale, you could either go back to a training job after about 6 months or 1 year, or you could go through a different route called the Caesar route, wherein you fill in your Form 16. Form 16 is you complete rotations in all the super specialities, and you complete the amount of competency required. Like there are specific numbers, like you should have done 500 cataracts, you should have seen 10 squints, you should have done these many ptosis. And if you complete those criteria and get yourself signed off, and you have completed your FRCS OFT. So if you've completed your FRC OFT and you've completed your Caesar, then you can apply to be registered in the GMC under the specialist registration. Now, as international medical graduates, we get registration as in the general specialist register. In order to move to the specialist register, you need to have these additional qualification. Either you could choose to do that and become a consultant, or if you choose to remain as in a non-training job as a middle grade doctor, that is also fine. Yeah. So yeah, that's about it. And yeah, could we discuss any questions at all? It was a long talk.
Thank you, Dr. Aswini. It was a really informative and enriching talk. Myself, Dr. Gayatri. Yeah, I just wanted to know the CESR which you said just now for the last slide.
Yes.
So how long it takes for the CSR to complete? Because it sounds to be a quite lengthy procedure. Like we have to, 500 cataracts and then whatever.
Yeah,
so how lengthy is the procedure?
So there are certain trusts and hospitals that have roles that support this kind of Caesar itself. So they will have 6 monthly rotation in every subspecialty, 6 months and 2 months as required, in order for you to complete those numbers and get yourself signed off. So if you choose to go for these jobs, are called OLT jobs, and they are advertised in specific trusts in order to support these candidates to fulfill their Caesar criteria. So if you're able to get such jobs, you will finish your rotation by about 2 years or 3 years. But even if you're not in an OLT job, you can still get yourself, when you get your first job, you can negotiate them that with them that if they support you for your Caesar or not. And if they do, they will post you on a rotation in different subspecialties based on what specialties are available in that hospital and what are the vacancies. Now, unlike training jobs, a non-training job is not mandatory. It's not mandatory for the hospital to do the rotation for you as you ask. But if you can negotiate that when you join in itself, they will be able to do that. So you should be able to finish all the rotations within 5 years time. You can't say that I used to do squint surgeries 10 years ago and that can be counted in Caesar. No, that should be within the past 5 years. So you set your rotations as such, and there are certain jobs that can finish your Caesar even in 2 years. So it's possible, but you should be prepared to travel different trusts within the deanery, or move houses if your personal circumstances allow. But if not, then you do it in your own hospital, and you negotiate with your lead, and you can bring that up in your appraisal as well. So every year you will have an appraisal in the hospital wherein you reflect about your previous year, and if you have any concerns about your job plan, that can be discussed with and agreed.
Okay. Thank you for answering. I think we have few questions in the chat box, Dr. Aswini. Can you just make a note? Yeah.
Aswini ma'am, I'm Dr. Kirtana, and thank you for the wonderful narration. And it was like as if we have been in every stations of the exam, gone through the exam, and we have traveled with you, along with you through UK. I feel like that. So thank you so much for the beautiful narration. And I have one doubt, ma'am. Like in case, like if you're opting for a training job there, then how long will it take for you to become a consultant rather than the other FRCS off group and CSR?
So it depends on your years of experience as well. So here the training job is about 7 years long,
Okay.
which is 3 years of general ophthalmology. Then you choose your subspecialty as an ST3, ST4. You start with an there is medical school of foundation year, that is foundation year 1 and 2. Then you go on to your core training, which is a CT1, CT2, and you start with your specialty training as ST1, ST2, ST3, ST4, and unlike where we usually get trained, your salary will not be much compromised as a trainee. So you don't have to really wait to be a consultant in order to be able to support your family. So you will still be earning a good salary in order to in order to lead a good a middle class life here. So
okay.
So if, with an experience of, let's say, 4 or 5 years in your home country, you can apply straight away to through a bypass route to an ST3 or an ST4 level, and from there it's about 3 or 4 levels of super specialty training, where you will be rotating different deaneries to complete your specific subspecialty before you become a consultant.
Okay, ma'am. Thank you so much.
Yeah, Dr. Aswini, just the chat box is telling few questions. First is from Nivedita. What is your suggestion, ma'am, if you don't have exposure to all clinical exam cases?
So Firstly, it's you're talking about private. If you're in private practice and you can't see exam cases, is it?
Dr. Nivedita, if you can unmute yourself, please.
Clinical exam cases. Okay, so
yes, ma'am. Yeah, you will be working in general, like you won't be working in very good hospital. You will be doing general practice. What will we do, ma'am, in that case?
so
Like you won't be seeing all retina cases or glaucoma devices.
that's right. It's quite challenging in that case. But so what helped me was when I was doing my part 2, I was doing my subspecialty training where I was tuned only to medical retina. But when I chose my first job after my fellowship, I made sure I see the outpatients, seeing general ophthalmology and seeing medical retina, so that I don't miss out on these cases. So when I do general clinics, I see a pool of cases, be it cornea, uvea, or neuro depending on the kind of hours I choose as well, and the location of your sitting. But it's like what they say, the eye will only see what the mind knows. So even in your regular cases, when you are tuned to look for problems and describe your cases, you can use the notes or the photographs to discuss with your friends and present these cases and form a management plan. If you cannot see cases regularly, you can affiliate yourself to a medical college or a training center nearby and do a rotation of it about 6 months or so, or even a fellowship or a short training in general ophthalmology, or there is a fellowship in general ophthalmology as well, where you do rotate to see cases. That will help. For me, it wasn't a problem because I was doing general ophthalmology as well. I chose to work like that so that it helps my exams. And one of the things that helped me was like what I told, the training in Lakshmi Eye Institute in Panvel. It's in Mumbai, where we were shown different kind of exam cases on one of the days, and each of us were allowed to present cases. So now where I work, I don't get to see a lot of penetrating keratoplasties or keratoconus or retinoblastomas and things like that. But when I did the course, and because it's a tertiary referral center, they do have these cases, and they do arrange for these cases on one of the days where you can look through them. And it's more important not just see by knowing what cases I got in my exam, or if what somebody got in their exam, you're not getting anywhere. Your cases might be the same. There may be different people attending the same exam with the same cases, but not all of them pass. Eventually, what matters is your ability for, of course, theory forms a strong base for your answers, and your ability to streamline your answers to suit that scenario at that point, and your ability to talk. So when you know everything but you've never rehearsed it, when you've never answered questions to somebody, it doesn't come out in the exam as well. Don't think that suddenly you will be able to answer suddenly in the exam when somebody asks you under a lot of pressure, when you know everything. But you need to practice that. So you can form small groups of people who are preparing for similar exam, maybe at the similar dates as well, and try to discuss cases. These cases could be virtual cases. Pick up a photo from the Google, or even the Telegram group has case discussions with photographs. So they give you a case scenario. You need not see the patient physically, but you know of, if you see photographs or if you have descriptions of the cases, like you will still be able to clear the exam. That's what I feel. That's the way to look around it. Yep.
Okay, thank you, ma'am. Thank you so much.
At this point, Dr. Aswini, I would just like to add
Yeah.
that As far as my knowledge, the Lakshmi Eye Institute, their FRCS Part 3 training course where Dr. Rashmin Gandhi and others
Yes,
used to
yes.
teach, I think they have discontinued it. Maybe it is due to the
Due to
pandemic.
COVID, yeah, maybe.
Yes, and also CFS Delhi, the Center for
Yes,
Sight Group by Dr. Honawar sir, even
yes,
they used to conduct, even they have discontinued.
correct.
So, yeah.
So probably it's going virtual, or is it because of the number of cases?
So this CFS has a PG training program. The
Mm,
modules are going on. Uh, I get notifications on Facebook group.
mm,
What they had told at earlier is, in the end, by the end sessions, they will include the exam-oriented topics of ICO and FRCS. But
mm,
they are still they have still going on glaucoma. So I
mm.
think we'll have to wait. And if any intimation I get, I'll put it on the group of our
Yeah, that will
so
help
the others
everyone.
also.
Yes. Yeah. I
Yes, yes.
mean, this is
So
one of the course that I found at the time when I was giving exam, but I'm sure many such courses happen when you are in a group of many people with from different parts of the country and from the world. You whatever courses you come across, you share with others, and thereby you meet more people. You form your own groups of friends. I had a group of 4 girls. All of us were from different parts of the world. I was from Bangalore. I had a girl who was in Kerala. One of them was somewhere in Rishikesh, and the other one was in Abu Dhabi. So we had different time frames, but we used to discuss, we used to send audio notes of the cases that we are reading and the cases that we want to present, and each of us ask questions to each other. I think that itself is a very good experience. But no doubt you need somebody to mentor you when you do examinations like cover test, confrontation, motility. These are things for which I feel you need, you can look at YouTube videos. That's one way to learn it. But if you have somebody to correct you or mentor you, that would help as well. So feel free to become each other's teachers. So there are some more questions.
Yeah. Dr. Ashwini,
Yeah.
can I just ask you one question?
Yes.
Yeah. Actually, in your station, one of the things regarding glaucoma which you told,
Yes.
that you were asked about glaucoma. You were asked to do a confrontation test, and later you were asked to do a perimetry. Can you highlight it more about that perimetry? What you were asked to do?
No, I wasn't asked to do a perimetry. I was asked to do a confrontation, and then I was handed a visual field and asked what was in the visual field. So to confirm my confrontation. So with confrontation, I know that it was left-sided hemianopia. With the visual field, it was correct. The left-sided hemianopia was seen on the visual field as well, and it was a congruous defect. So you know that the lesion is more posterior. So from there, the discussion went on to where do you see lesions like this, and what could be the causes, and if you come across one such case, how will you deal with it? You will talk about doing an MRI and locating the lesion, but what they want to, anybody can do an MRI and see if there is a tumor here or a vascular compromise. That's not the crux of it. With your clinical skills, how would you locate whether it is a tumor or a vascular lesion, and if it is involving just the occipital lobe or if it is involving the parietal lobe as well. So then I said I will use an OKN drum, optokinetic drum, to look for pursuits, and if pursuits are affected, I know the parietal lobe also could be affected. And with Kogan's dictum, I would decide whether it is a tumor or a vascular lesion. If it is a vascular lesion, then you liaise with the GP and do the necessary investigation to look for vascular causes. You will do a ESR CRP to look for GCA, although GCA is not the only cause for vascular lesions. Then you will MRI will be there to say whether it is a tumor or not. So the discussion went on like that, but you will never be asked to do a perimetry to learn the peripheral extent. Like when they asked to do the extraocular movements, yes, or I said I will start with the cover test, but then they said skip that. So they know that I already know that I need to do a cover test first to start with the next examination. So you do your protocol, but they will cut you if they feel it's not needed. and don't be nervous about that.
Oh, okay, thank you. Thank you, Dr. Aswini. Well, the second question is, do you need to be a subspecialist to apply for a job in UK, in NHS?
No, you
Or
don't. You don't.
you know, no need.
Yeah, you don't. Now, I have friends of mine who have just finished their post-graduation, not subspecialized, but they finished their FRCS and they've applied for a job and they've got into the same role as me, same pay scale as me, and they're doing very well. So your fellowship is not a must, but whatever fellowship you've done back home will be focused on and will get you a better chance of securing a job here. And your job plan will include more of your subspecialty clinics. Like I do more of medical retina clinics here, and few of general ophthalm. There is a concept of something called high casualty here, wherein we see acute ophthalmic cases in that clinic. Sorry. Yeah, so your job plan will be tailored accordingly, but more or less you can get the same job.
Okay, thank you, Dr. Aswini, for clarifying.
Dr. Aswini,
Hi.
this is Dr. Ali Amjad Hassan. Hi. Oh,
Hi, how are
your talk was very informative. Thank you for the question. Alhamdulillah, I'm fine. How are you?
I'm good, thank you. How are you? Yeah, tell me. What was the question?
Yes, actually, yes. My question is that what if we FRC off and what are the prospects in the future?
If you do your FRC off, it is a even more better chances of getting through. But then the standards of the exam is quite tougher than FRCS Glasgow. Glasgow is a much easier exam to crack. In fact, the easiest of the lot. So and FRC off plays. It has the major part of FRC off involves refraction. So there will be a refraction station where you will be asked to refract a patient and give your answers, and that's very essential to pass. It's a recognizable qualification in the GMC, but despite FRC off, because you don't have your competency signed off with Caesar, you will still land up in the same job as anybody with an FRCS Glasgow who's cleared the exam easier and quicker. But you are spared of that another attempt of finishing FRC off in future when you want to become a consultant. You can always do that. Take your time, do the exam, and get yourself into the UK. And then when you're in the UK, you can do your Caesar, because or you can get into the training job and follow the training pathway. That's another way as well.
So how long does this training job work? Like you told 7 years.
Yes,
right?
And it's not 7 years in one place. You should be prepared to rotate different hospitals. So you may have to move houses. Your kids may have to move schools. So and some trusts most trusts do have on-call rota as well. So when you are here in the training job, most often you do your on-calls. But there are some trusts which you can apply which spare you of the on-calls if you're in a non-training job, if that works better for you.
Dr. Aswini, at this point, I just wanted to ask the difference or the difference between the weightage or difference between the perspective about FRCS Glasgow and FRCS Edinburgh, since now even the Edinburgh exam has been opened through the ICO route, and recently the association is stopped, but since it is now doable even for the non-UK people. So can you put any light on that?
As far as I know, you could go through your FICO and you could get your membership in Royal College of Edinburgh.
Correct.
So
that has been terminated.
Yes, you will get your
so that has been terminated from March 2021.
Exactly. So with that, they did open this route of GMC registration through MRCS Edinburgh. But once the FICO got a bypass into MRCS Edinburgh, after a few months, the GMC registration failed to recognize MRCS Edinburgh. So these things are quite dynamic. They keep changing. So whatever works best for you, it might even be that you start preparing for an exam, part 1, part 2, part 3. By the time you end, the rules change. So it's quite labile that way.
And in the exams per se, how is the weightage, or both are equal, the Glasgow and the Edinburgh?
When
the
you apply for
FRCS
jobs,
titles.
yeah,
Okay.
when you apply for jobs, they will look for any Royal College exam that you've given, whether it is Edinburgh or Glasgow will not have much weightage, because you are not FRC off, you are FRCS Glasgow. That difference will be there. And if you have cleared your Royal College exams, that tells to the interviewing person that you have upped your knowledge, you have done some studies recently, and you have you're not lost in your in your journey. And it definitely gives you an upper hand over somebody who has not done FRCS or gone through a PLAB route. Like there are jobs of SHOs and ST1 levels that you can take up if you got your GMC registration through your PLAB route. Although that's quite faster, you can clear your PLAB in a short duration, and it's an easier exam compared to FRCS. But your competencies will be considered lower, so you will take a job, and along with that, your pay point will be of a starting level. Unlike when you're with FRCS Glasgow, similar, but FRCS Glasgow to FRCS Edinburgh, there is not much difference. If you can prove your competencies, your CV speaks about your experiences. If your numbers are higher, and if you're confident in your interview, that should not matter. All they require is GMC registration. How you get your GMC registration is not their concern, whoever interviews you.
Okay. And another thing, for non-UK, I mean, if you're not settling for UK, but still if you're trying for FRCS exams, does appearing and clearing Edinburgh and Glasgow gives any added advantage, or over clearing only one?
No, it's the same. You're just paying more for the exams. And it's like, what do I say? It's like doing, let's say, MBBS in Karnataka and MBBS in Delhi. You're doing the same thing.
Okay. Because there is a lot of misconceptions, since like we can go on adding up the double FRCs, the double
That
FRCs.
is there. If you are in private practice in India, where you have a board of yours and people, you need patients to see your post nominals, and that's an added feather, no doubt, because you have more letters against your name. That's definitely there. But when you come to the UK, that's not the case.
Okay.
You are just like another doctor. There is no competition amongst doctors, because patients don't get to choose their doctor, and you can't go for second opinion to another doctor. So this whole concept of shining bright doesn't exist here. But if you're into private practice, that will definitely help you. You can do FICO and then FRCS Glasgow. That gives a double post nominal instead of FRCS Glasgow alone. Whereas in the UK, it's one thing. Or if you do FRCS Edinburgh and FRCS Glasgow, in your home country, you can add more post nominals, and of course your clinical knowledge would be better. You would be more experienced. You would have prepared better, and your chances of giving FRC off is higher. So no doubt there is no end of giving exams, both for gaining professionally or just for the joy of giving exams, really.
Okay.
Ma'am, I had a doubt regarding the internship completion certificate. You mentioned that I have a certificate given by the university which says that the internship started on this month of this year to this month of this year.
Yes.
Is that the one we are required to produce, or
yes, but that certificate should also have how many months you've done in each specialty, like medicine 2 months and gynae 2 months and ophthalm maybe 15 days, 1 month, whatever it is. It should state the duration from when to when you've done each subspecialty. That's required.
Okay, ma'am. So
because your internship could have been in just 3 subspecialties over the period of 1 year, but that's not accepted.
Okay, so the details from the university is also required.
Not from the university. Usually the internship
The
certificate does say your duration in each department. If they don't, you can request for them to give you a descriptive certificate which says duration of your rotation in each specialty.
Okay, okay.
Dr. Ashwini, one more question in the chat box. Dr. Alia Amjad Hassan. No, sorry, from Dr. Abid Nawaz. I think he wants to know about the kind of salaries that one can expect once one gets a job offer.
That depends on the kind of job you're applying in. If you go to Road to UK website, or you can just type pay scales of NHS doctors in Google, you will get it's all completely transparent. Anyone is accessible to the pay scales. So it depends on the pay point that you are on and the grade of doctor, the job grade that you are opting for. So there will be a range, like for a middle grade doctor, the salary will start from somewhere, I think around £38,000 per month to up to £70 per month, depending on your number of years of experience. So that depends on which pay point you end up based on your experience and what job profile you will. Yeah, so that's that. Is it easier to do training jobs?
Actually, when
yeah,
I'm Dr. I'm Deepthi speaking. Ma'am.
Hi, Deepthi.
Hello, ma'am. Ma'am, actually, I had a doubt. Like when we give our experience letters wherever we have worked,
Correct.
like in what form do they ask, ma'am, for experience? Like a written letter
That will
from
not matter at
wherever
all.
we have worked?
You can have your experience letters, but when you opt for a job in the NHS, you will have to give in your CV a contact detail of 3 of your referees, 3 or 5. So you can mention few referees. Referees should be somebody who has supervised you directly at your workplace, and you give their contact numbers in terms of their email address, which is how they normally contact them, and their telephone number and their physical address. So the trust and the agency that puts you through the job will send a reference email to these doctors, and they will ask, there will be a preset questionnaire for them to answer, which talks about your skills, your communication skills, your surgical skills, and arrange for them to mark. So they will respond to that email. And although you get a written testimonial from the places that you worked before, they might not be handy right now when you apply in the NHS, because it might not be up to date, as it might be a few years ago. But when they contact the doctors, you just let your mentors know that you will get an email and kindly reply to that. You can give them a call and explain about your job offer and where you plan to go. And they should normally reply back to that email. So that's the way reference checks are done, instead of you handing in a preset descriptive paper.
Okay.
And that's the case, I think, in most places, because when I applied for a job in Singapore as well, that's the way the reference check was done. And NHS, that's the way it's done. I think US as well, it's the same way. So you may have a testimonial, but referees are directly contacted. Yes.
Okay. Thank you.
Ma'am, parents are not allowed to be taken during the initial phase, or even when you get settled after 2-3 years. Can we take the parents? Is it possible, ma'am?
Nothing like they're not allowed. You could move along with your parents itself for when you go, but they are not allowed to stay for more than 6 months. That is not just in the initial stage. Even if you become a UK citizen, you will be a citizen. Your dependents are considered to be your other half and your children. But your parents until now are not considered your dependents. That's one of the cons, like I told you. So you can take them on a 6-monthly visit visa, after which they have to touch down to the home country for at least 3 months, and then they can revisit you again. So this can happen over a long time. Usually what people do here is you will have a paid annual leave for about 28 days or more. So that 28 days is 28 working days. So 5 days a week will be 1 week of holiday, including 2 other weekends. So normally what people do is take 2 weeks or 10 days of holidays at once in 6 months, they go visit home. So that can be twice a year as well. So that way you can have the good part of both worlds. Or you can get, right now my mom's with me here. It's just been 2 years since I moved to UK. I've got my mom here twice. I've got my mother-in-law once, I've got my mom once. So it's possible, it's not a big deal. Yeah, so they stay here for 6 months and then they go back to India and they visit back when they want to.
Thank you, ma'am.
And that can be right from your first year. There is no restriction in your, it's not like you're new to UK, so you're not allowed or anything. In fact, anybody can visit the UK on a visit visa. Even you can visit before you get a job on a visiting visa if you have a purpose of visit. Even as a tourist, you can visit. It's just that when you have a job here, you are sponsoring your parents' visit here. So you just have to show that your parents, they may ask you for your parents' a bank statement so that they know they have sufficient funds to fund their stay here in the UK and they have something to go back to and they wouldn't stay here for long. Because any person staying here for long, they will, like when you reside in the UK for more than 5 years, you qualify to apply for indefinite leave to remain or your ILR, which in a year will translate to you being a UK citizen if you wish to, or you could just remain on ILR lifelong as well, and you could retain your Indian citizenship. So you can stay in the UK for as long as you want and you could still be an Indian citizen.
Thank you, ma'am.
Yeah, Dr. Aswini, this is Dr. Nawaz.
Hi, Nawaz.
Yeah, hi. Thank you for the talk, by the way. It's a really good talk. My question is regarding the scissor route.
Yes.
You had mentioned something regarding the surgeries that are required to actually go through with the scissor route, like certain amount of squint surgeries, and you have to visit all the deaneries and do stuff like that. My question was whether the surgeries that you do in India, are they counted toward the scissor route? Like, are they honored in any way? Like if you provide documentation on any logbook, sort of like if you have done squint here, or does it make the matter more easier, or do we have to do them in the UK?
No, you can do it in India as well, as long as your the person who signs you off for these competencies should be a consultant level, or I think should be GMC registered. So then they can sign you off for these competencies, and if it is within 5 years of your application, it is counted. But if it is before, like if I have done cataract surgeries in India like 7 years ago, and I'm applying for my Caesar route, and considering those surgeries, it may not be counted. It's just to show that you are able to do these these kind of surgeries even now, and the skills have not attritioned. So if you look for bigger institutes like Arvind and Shankara, usually there are so many consultants who are FRC off and who could be GMC registered as well. So when your mentors are GMC registered, I'm not 100% sure, but you could check on this. If they are GMC registered, that is when they can sign you off for your competencies, which will stay valid for your Caesar route.
Thank you, Dr. Aswini.
There are these numbers stated on the RC of the website. If you look for Caesar route competencies required, you will see a list of number of surgeries. Then you will get an idea. But if you want to do it in a shorter time, then you could choose for an OLT job, which gives you a suitable number of rotations. Because although these numbers sound high, but for a trainee who gets trained in the UK, they have to complete a minimum of 700 cataract phacoemulsification surgeries by the time they finish. And unlike our home country, here the responsibility of the trainee having completed that amount of cataract surgery is on the consultant who supervises him. So the consultant definitely makes sure that he finishes this number of cataract surgeries in the rotation that he is with him.
Sure. Thank you, Dr. Aswini.
Yeah, that's why the expectation.
Yeah, another question I had regarding the auditing and the governance that you were mentioning. Does it make a difference if you do the auditing in India? Like, does it count? Or because a friend of mine who's from the UK himself advised me to get the auditing done in India itself because they're a lot more regulated in the UK and we can get them done in an easier manner in India. Is that true?
I mean, it depends. If you are looking for a training job, then yes, they will ask you for any audits that you've done. But if you're looking for a middle grade job or a non-training job, then they will ask you if you know about audits. In your job interview, there will be questions about audits, what you know about them, and the amount of material is easily available. If you've done an audit, well and good. Anywhere should be okay. India or in the UK should be okay.
Yeah, the last question I have is regarding the training jobs in the UK, how difficult are they to get into? Like, what my understanding is, I was in London 2 years back, and what the mentor of mine there said was they're practically impossible to get into because they're highly sought after by all the UK nationals. Is that true, or do you know anybody who's non-UK and got into the training job at an ST3 or an ST4 level?
No, it's like in any country, they will have a quota for their own citizens, and there will be a quota for non-nationals. So when there are seats that are chosen, they get the first preference. After the local candidates get their seats sorted, that is when it will be open for the non-nationals. So it depends from year to year on how much is the probability of getting a training job. But I know of a few friends who have so what most people do is get into a non-training job first, make the move to UK, which is when it is easier for you to crack the interview and get into the training route. So they finish 6 months or a year of work in the UK. Meanwhile, they give their exams and they get their basic competencies signed off. They upload their profile in the Oriel, get your interviews done, and you can go into training that way. So it's not impossible, but it depends from specialty and subspecialty, wherein ophthalmology is quite a sought after specialty. It's not impossible, nothing's impossible, but I must say it's quite difficult to crack.
Thank you, Dr. Aswini. Thank you for patience and your knowledge. Thank you.
Ma'am, like you said, that nationals would get a preference first. What if we have done a post-graduation from a university from the UK? Will they get?
No, you should be a British national or you should be a citizen here. That's what is counted.
Thank you.
Yeah, so I think we've gone through most of it. If any more questions, we could always discuss on the WhatsApp group. And I'm really thankful to all my mentors who've helped me go through this. And hopefully we all get to where we want to get and do our exams really well. Yeah.
Thank you, Mom. Thank you so much.
Yeah. See you. Bye-bye.
Thank you, ma'am.
Yeah,
Thank
bye.
you.
Thank you, ma'am. Thank you so much.
Yeah. All the best for all of you. Bye.
Thank you.